And now I want to turn and introduce an old friend, Tom Banning. Tom is Chief Executive Officer of the Texas Association of Family Physicians. His title today is Cost Trends and the Inevitable Legislative and Market Pushback. Tom is from Austin, Texas. He is a graduate of the University of Texas. He is the Chief Executive Officer for the Texas Academy of Family Physicians. We've worked together a lot on issues related to that. His duties include directing strategy, political action, and continuing education. I am so much a fan of Tom's because Tom's been talking about a Marshall Plan for primary care and public health now for a while. He's reintroduced a concept that he formulated, I think it was back in the late 90s, maybe, Tom, when you were talking about regional insurance network zones.
Yep.
As a way to be sure we had uninterrupted care. Tom Banning is one of those people who can take the practical matters of today and imagine a different kind of future. Tom, I'm delighted to introduce you and to listen to what you have to say, sir. Thank you for being with us.
Thank you, Billy. I appreciate you having me. I'm not as lucky as Alan in being able to use my wife's office. We don't have one, so I kicked my kids out of the playroom and am using their playroom. So you can see the toys and the board games in the background, and this was about the quietest spot that I find in the house. Listening to Alan earlier give a fantastic presentation, I did not know about Starr County, and it turns out that my current president, Jake Margo, is actually from Starr County, is practicing in the hospital today. So I texted him and I said, hey man, congratulations. I'm on this Zoom call, and it was just announced that Starr County had broken the top 10 for the highest increase in positivity in COVID cases. And he texted me right back. He goes, man, it's been a beating of a day. 2 of our hospital staff were part of that. I've seen all of these patients coming in, and but he was like, that's how we roll in Starr County. So we both got a kick out of that. I don't have any slides today, which will be good because I'm not really technologically technologically enabled person. The only problem is you're gonna have to look at my face the whole time. So for that, I apologize. I know that my presentation was titled Healthcare Cost Trends and Inevitable both market and legislative pushback on those trends. I think that COVID-19 has really changed the trajectory of a lot of things, and one of those being really a deep dive on healthcare costs. But we're going to talk about that. But I also want to spend a little bit of time talking about both some of the challenges and opportunities that I see coming up over the next 12 to 18 months. So kind of kicking off on the healthcare cost piece of it, I think that the reason that Mike and the group wanted me to visit was earlier this year, Speaker Bonin had appointed a select committee on healthcare cost trends. And the committee was charged, and I'm going to read this, to examine the current healthcare financing, Texas's current healthcare financing strategies, fragmentation of care delivery and administrative burdens, population health and social factors that contribute to rising rates of chronic disease and poor health, insurance coverage and benefit design, lack of transparency in healthcare services, regional variations in the cost of care, consolidation and lack of competition in the provider and insurance markets, healthcare workforce capacity and distribution, and look for opportunities where public dollars spent on healthcare could be better coordinated. So it was a pretty comprehensive undertaking that the legislature or the House was going to take on. Since that charge was announced, we were working very closely with the chairman of that committee, Dr. Greg Bonin, who's a neurosurgeon down in Houston. He was tentatively scheduled to have his first hearing. I believe it was the last week of March, first week of April. Obviously that did not occur. And kind of the continued proliferation of COVID has really the legislature in a place right now that they're just not sure what they're going to do, what they're going to be able to do. I got an email earlier this morning that 10 additional DPS officers had tested positive for COVID-19 at the Capitol. The Capitol is still not open. Legislative work and interim work really can't happen because the members can't come together to take public testimony or even take invited testimony. The House rules are somewhat restrictive in terms of what's allowed in terms of the ability to meet in a virtual fashion. So, how this committee moves forward is really anybody's guess now. My sense is, and I've talked to Dr. Bonin a couple of times, since March, is that there's a good chance that the committee, will not meet. But it is his intention to still do a report and focus on a couple of those issues that the state needs to be thinking about come next session. We had talked about the committees doing work groups or subcommittees, and he was very interested in doing a subcommittee on rural healthcare. And there are 3 members on that committee, Cody Harris from Palestine, James Frank from Wichita Falls, and Cole Hefner from Mount Pleasant, that Greg had intended to spearhead a review of rural healthcare. I think given the fact that they still want to take tests or they still want to do a report, those members are going to have an opportunity to influence what's in that report. I know, having talked to all 3 of those members, they are all passionate about rural healthcare. And I think that there are some opportunities to work with them to make sure that the voice of rural healthcare is included in whatever that final report looks like. So for individuals on this Zoom call that are, in those areas for the organization, I'd really encourage you to reach out to those members. And if you've got policy ideas that you want to bring forward, I know that they'd be interested in hearing that and making it part of the report. One of the more interesting things, and Billy alluded to it earlier, that we've been working on, and I'll try to encapsulate this as best as I can. Back in 1997, the legislature passed some laws, and they were amended in 1999 and again in 2001. They passed some laws that established what was at the time known as the Rural Community Health System. It was initially created to respond to the rollout of Medicaid managed care. And, obviously back then, Texas really didn't have a lot of experience with managed care. Certainly rural areas didn't. And some rural legislators thought, rather than vending out the Medicaid program to out-of-state for-profit insurance carriers, we really needed a locally owned, homegrown product that would foster appropriate and natural linkages and referral patterns among primary and tertiary healthcare providers in urban, semi-urban, and rural communities. Really keep funding of healthcare local, provide community linkages and coordination resources, and really just have a rural option for Medicaid managed care. In 1999, maybe it was 2001. In 1999, the legislature came back and we had not yet rolled out Medicaid managed care. And they said, hey, we still like this concept and this model. Why are we limiting it to Medicaid? Why don't we give RCHS the authority to enter into or provide health insurance to school districts, to employers, to individuals, to anybody that needed insurance in a rural community. In 2001 or thereabouts, the Commissioner of Health and Human Services made the decision that they were not going to contract for Medicaid services with RCHS. They were going to utilize more established managed care entities. And the company that was basically backing or financing the RCHS pulled out its support because there was not really a business model going forward. So interestingly, that was one of the first projects that I was involved with when I started a long time ago. And I was speaking at a UT Health Law conference down in Houston, and an old friend came up to me who happened to have drafted the enabling legislation to create RCHS. She asked, hey, is that statute still on the books? And I was like, I can't believe that it would be, but let me check. Every agency has to go through what's called sunset every 12 years, and I would have thought after the Department of Insurance went through sunset that provision would have been stripped out of the insurance code. Well, lo and behold, in Chapter 20C of the insurance code, there was the RCHS. And it got me to thinking, based on the issues facing rural health, could this be a model, if we are not going to expand Medicare, to create competition in rural communities, to create other access points for rural communities, and went to the University of Texas's Texas Health Improvement Network and asked them to take a look at the law and see if this might make sense for the legislature to consider going forward. So about a month ago, we met virtually, and the committee, which Dr. Phillips serves on, agreed unanimously to do a study that is going to basically conduct an environmental scan on health insurance coverage options in rural communities and factors contributing to low insurance coverage in rural areas. Look at where health insurance options are limited and describe the impact on rural physicians, hospitals, employers, and patients. So, we understand that there's very few carriers that want to go into those markets. We want to understand why, to try to increase options in those areas. The study has also charged to describe what the RCHS concept is and how the RCHS or another community-owned health plan could potentially impact coverage options and healthcare access in rural communities, and then look at pitfalls or unintended consequences of enacting an RCHS type model to maximize benefits and minimize pitfalls. I don't think I need to tell anybody on the call that there's, when you look at carriers that are in the rural markets, you got really two Medicaid providers and then one company that starts with letter B. And when you have that level of market power, it creates some really challenging issues, both for employers or individuals that are buying coverage because they can set the price because there is no competition, as well as for physicians, hospitals, and other providers that are providing services, because if they're the only game in town, then they can tell you what they're going to reimburse in a take it or leave it situation. Obviously, this was very appealing to Republican members that liked the idea of competition because whether correctly or not, competition does generally bring down price. One of the limiting factors of accessing coverage, it really is the cost of care. The other interesting thing that I hope that this study does is really allows local communities to, think about what they need and they want in an insurance product. When you think about the Affordable Care Act or Obamacare, there are essential health benefit requirements that all insurers are required to provide. RCHS is different because it acts like a self-insured entity, so it's not a fully insured product that could, and it's also a public-private partnership between, because it's regulated, because it's the board of RCHS would be appointed by the governor, and it is made up of local community providers and interest, both patients and employers. Could it be viewed as something that would not be required to comply with the essential health benefits? And could that help drive down the cost? So a lot of exciting conversations about some different models than what exists today that could improve access to care. So let me talk about a couple of things that we've been working on, and then I'll touch on kind of what I think the legislature is likely to do next session. As Dr. Phillips had mentioned, and Alan had mentioned as well, when the coronavirus struck in March, we saw family medicine physicians across the state saw volume drop somewhere in the range of 50 to 70%. And it was a gut punch. A lot of practices pivoted to virtual care and opened up access to their patients. But those in-office visits really went away by and large. And in a fee-for-service environment, volume drives reimbursement and drives revenue and drives operations. Even though a lot of groups were able to pivot to telemedicine, we really didn't have a lot of clarity on payment rates, both for Medicare, Medicaid, or the commercial insurance market. And even for, and that was for the first couple of weeks. Medicare came out pretty quickly and said, we will pay at parity for an in-person visit. Medicaid followed suit. Medicare came back and clarified that they would allow telephone calls to comport or comply with a telemedicine visit at an in-person rate. And then the commercial insurers said, as long as the public health emergency is in place, we will follow suit and pay for this. The challenge, at least in urban areas, maybe not so much in rural areas, is that a large number of employed lives are self-insured, which means that neither the state or the feds can regulate those payments. It's really up to the employer. So even though we thought we had some clarity around payment issues for virtual services, you might provide it, you might get if you did provide it, you might get paid, you might not. The other challenge was by missing an in-person visit, you couldn't bill for ancillary services virtually. You couldn't do lab work. You couldn't do X-rays and other services. Which what we found was a drop of revenue in the range of 25 to 30% of a typical office visit. So it got several of us talking about, is this an opportunity to start talking about prospective payment? And Alan touched on that in the experiment that's going on in Pennsylvania. And, is this something that would make sense? How long is it going to take us to get back to, physicians' offices being full, being able to generate, the fee for service revenue to keep practices open, because virtual just wasn't doing it. So should we begin having a conversation about prospective payment? And we began working with a couple of groups around the country, including the group called Health Rosetta, which is really based up in the Seattle area, the American Academy of Family Physicians, Aledade, Catalyst Health Network in Dallas and in East Texas, Village MD down in Houston, in Southeast Texas, and in a few other states, about, we need a Marshall Plan for primary care. And it starts with moving our payment model to something other than fee-for-service, because fee-for-service has failed primary care. The COVID-19 pandemic has exposed those failings. And, while some specialties were able to really close up shop, when some hospitals were, forced to, close down elective surgeries, most primary care offices remained open, but they were running two concurrent business models, with a bricks and mortar office still open for those that needed to come in, and at the same time providing a virtual platform for care. And as we were, talking to reporters and policymakers, we tried to make it very clear that, COVID is a huge problem. We're doing our best to screen for it, to test for it, to set up different protocols to manage it and keep patients safe. But chronic disease has not gone away. Acute problems have not gone away. Heart attacks have not stopped. These physicians need to keep their doors open to keep access open, so patients don't hit the emergency room, so they don't go to the hospital. We're high risk vectors for COVID-19 spread. So, is additional part of the primary care, or the primary care Marshall Plan, was better utilizing telemedicine services for. Sorry, my son just turned on the TV and I just noticed it in the background. Sorry about that. Better utilizing telemedicine services, and allowing physicians to use the technology that they saw fit for their patients. We were hearing from a lot of program directors that, family medicine program directors, that some of their elderly patients didn't want or like using FaceTime or virtual visits like Zoom, or even the HIPAA compliant ones. They just thought someone would hack into their visit and take over. So having the flexibility to use the telephone was a huge benefit. Another part was right sizing our workforce, making sure that we're training and preparing doctors for what the state is going to need going forward. There are a couple other elements of the Marshall Plan that we're finalizing. Some of it's around coverage expansion, and a lot of it's around better utilizing our public health infrastructure. There's a lot of emphasis going on right now on contact tracers and contact tracing. And, I envision this working really well, I mean, is integrating contact tracing into population health services that physicians are providing their patients. And if you think about some of the challenges that um, that disease management, I'll just pick on disease management, had when it rolled out, is the insurance companies tried to go out and sell a product to their employers that said, hey, for an additional $10 per member per month, we can better manage your high risk, chronic patients, connect with them, make sure that, they're staying on their medications, blah, 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 blah. Fast forward, 2 years, and it's not really worked the way they promised. Their success rate, the insurer's success rate on better patient management through disease management was like at 12%, maybe 18%, and that's because people didn't want to talk to their insurance companies. And my wife and I actually experienced this with our first child. We were insured at the time by a company that starts with the letter U. We had a wonderful OB-GYN physician that had a great prenatal program. We worked with their group in, making sure we were doing all the visits right. I think we got 3 or 4 phone calls from that company's disease management team, trying to enroll us in their prenatal program. And literally a week after we delivered, we got our EOB for what the delivery cost was and hospital cost was. After we got the EOB, we got the company's prenatal care package, which I just thought was incredible. That you had you're selling a product, making a claim that you could better care for patients, and then you were providing information resources after a service had been done. You fast forward, to today, a lot of those insurance company defined disease management programs are now embedded within physician practices, within groups, and they're paid for by a bundle or a care management fee. And I kind of, describe, or I think about contact tracing in the way that I think about what I just described. Right now, we are spending, I think, $237 million for a data company to go out and do contact tracing and reach out to patients, or not patients, reach out to individuals that, these groups don't know, the groups don't know them. Imagine if we could allow or put a bundle into a population health model for either administrative staff or clinical staff that has some downtime to serve as that contact tracer. It's a much different patient engagement when somebody calls from an insurance company or a data company than somebody calling from Dr. Phillips's office. The credibility that the physicians have could make a huge difference in having people pick up, having trust in, the public health part of it. And that's one of the recommendations that we're going to be making to the legislature next session is, as we move forward with contact tracing, how can we better align that and roll that into some of the services that primary care physicians are providing. So, looking at next session, I'd mentioned that, the Capitol is shut down. We're not doing interim hearings. We've got redistricting that's coming up that is a once every 10-year reallocation or realignment of political lines that's based on census data. The census data is going to be delayed. We really don't have the time or the ability to hold hearings around redistricting. So I think that's going to be pushed back. As I'd mentioned earlier, every 12 years, various agencies have to come up for sunset, and that's a very time-intensive, difficult process for agencies to go into review. We are already 3 or 4 months behind on sunset of various agencies, so I think that that's likely going to be delayed. Really, the only thing constitutionally that the legislature is required to do is to pass a balanced budget. And I'm sure that everybody has been, following and should not be surprised that, our tax revenues are down significantly since March when we shut the state down. The question is, to what degree and what is the number going to look like starting in 2021? California, I want to say, is looking at a $54 billion deficit. When you look back to 2011, I think we had a $24 billion deficit. I think most folks that I talk to are thinking, we could be looking at somewhere around a $40 billion deficit, which would be devastating to a lot of folks. And how we get out of that during a regular legislative session is anybody's guess. But it's a reality that that we're going to have to deal with, and whether that means new taxes. I know that there's been a lot of conversations occurring about additional cigarette taxes, additional taxes on sugary drinks. Other tricks that the legislature might utilize, whether we can get an enhanced FMAP from the federal government to put more money into our Medicaid program. Congress is about to do their fourth coronavirus package, hopefully by mid-July. Could there be dollars for states that would help close that gap? And people are talking. They're not really talking publicly or out loud about this, but could the state finally expand Medicaid to maximize federal dollars coming into the state? So I think the budget is really going to be the biggest issue that the legislature deals with next session. Beyond that, I'm not sure, again, depending on where COVID is, what they're going to be able to achieve, even from a meeting standpoint. I know that the House Administration Committee is putting in plexiglass separators in the House Appropriations Committee to try to keep members safe. But are they going to allow the public into the Capitol? How are they going to take testimony? How are they going to fulfill what open government is supposed to do in terms of allowing the public, as well as their advocacy organizations, to engage in the process? And I don't think that they've figured it out. And that's going to be a huge question mark going into the session. How can we really influence the session? So I got one other thing that I think you might find interesting and a little concerning, and then I'll stop and see if there are any questions. And you may or may not have seen it today in the Los Angeles Times, but at the end of last week, sort of the rumor du jour going around was that President Trump was going to end the public health emergency declaration, which expires, I believe, July 31st. And if you think about what that means, that declaration has allowed for the suspension of all of the rules that we talked about in terms of Medicare paying for telemedicine, physicians and hospitals being able to use non-HIPAA compliant tools, allowing hospitals to not go through the rigorous process of expanding hospital bed capacity, or hiring staff from outside of the state of Texas, and going through a whole bunch of other regulatory issues that they would currently have to. So if that public health declaration does expire or is allowed to expire, that means that even the rules that we want to keep in place, like the telemedicine rules, would be required to go through rulemaking, which means that the agencies would have to write rules. They'd have to take a 60-day public comment period and before those rules could go into effect, which could have serious disruption in the operations of a lot of things, especially if we're still in the midst of what it looks like to be a very long and difficult issue with COVID. So I'm generally a cynic, but I am optimistic that when we get to the other side of this, that there's going to be a much better system, both for primary care and for rural health. The COVID has exposed a lot of things that are broken with our healthcare system, but it's also exposed a lot of things that if we think differently about aligning resources, removing some restrictions and regulations, that we can really improve patient care and improve health, and that's what I'm gonna leave you with, and really focus on the positive side of this. So Billy, Mike, Kelly, that's about what I've got. I've got the chat on. Happy to take any questions, or if you guys have any follow-up for me, please let me know.
Terrific presentation, Tom, as usual. A wonderful set of things for us to think about. I'm looking at the chat, and there are a few things that come up. The July expiration of the order. Have you got any better sense of that we might expect it to be extended on a month by month because of the rulemaking principles that would have to come into effect?
Not to be partisan, but this administration is a chaos administration. I mean, it makes absolutely no public health sense that this would even be considered. But politically, I know that everybody wants to move away from COVID and start focusing on the economy and something other than what's happening. And I unfortunately could see, for political reasons, the administration declaring this is over, even when it's not, without thinking about what the implications of those things might mean. I do know a lot of people that are close to the president that are strongly encouraging him to not do that, to extend the emergency. Hopefully cooler heads will prevail, but I think it's something people need to be thinking about and wargaming about, if this were to come to an end, what would it mean to your ability to operate, to generate revenue, and how would you make up for it?
You have another question. Sonny Hire has asked, going back to when you talked about the COVID contact tracing, I mentioned that in my own talk, and Alan mentioned it as well, for a different reason, because we are everybody's worried about the fall. Well, you know what? In the rural areas, we're already there. We're surging. In Lubbock, for example, in the last 2 weeks, we reported more COVID-19 cases than in the previous 3 months. So that's going on all across rural America, except for very, very sparsely populated areas. So Sonny's question is, are you thinking that this would be a CCM type model as part of that training, rather than some data company calling out of the blue to contact trace you if you're a positive COVID case.
Yep, that's exactly what I'm thinking. And we've actually retained a firm out of Washington, D.C. called FTI, and they're working up that policy. But that's exactly how I envision it. It's just it's another bundle, right? I mean, you can call it whatever you want, but physicians have the staff, they have the relationships, and if they don't have the staff, they can bring it on, much like they're doing with their CCM populations.
Yeah.
And one of the other things,
it makes sense.
I see the question from John. Yeah, I mean, when you look at, I think public health coming out of this is going to get a real shot in the arm. When for the first almost 2 months of this pandemic, and I know John Henderson's on this call, our biggest issue was tracking down PPE for our members. And John, racing around in his truck with Matthew McConaughey, I understand, is kind of big time. Delivering it to rural hospitals. I was, trying to coordinate some stuff with our doctors. And, once we kind of got over that initial hump, and the state finally figured out, oh man, we got a real problem with PPE. The system that we have in place where they utilize the racks to be the key distribution point and access point. They figured out real quickly the racks don't have any relationship with the community doctors. So I think there's going to be a lot of conversations about how we can better align our public health infrastructure with our community doctors and local hospitals, and use technology to help in that communication and openness. And the Marshall Plan, kind of going back to that, we really think about the money that the U.S. pumped into Europe really built what Europe ultimately became. And, we've got a really once in a generation opportunity to think differently about how our healthcare infrastructure is organized and funded. And it'll take a long time to implement, but I think we have the opportunity to lay the groundwork for it now.
That's great. And John, I see your comment that's really not big time. I've always thought you were big time, but anyway, good West Texan who is CEO of the Texas Organization of Rural and Community Hospitals. What an important partner you guys are. Tom, do you see that one about the warehouse story? I know.
Yeah, I do. So,
so
I'll give you, since I've got a couple of minutes. In, I think it was the third week of March, when people were starting to flood doctors' offices, and most family doctors don't have a large stock of PPE. And there's this mad dash to try to get some. A friend of mine who's pretty entrepreneurial had a connection down in a manufacturing plant in Mexico, and brought up several thousand masks in a U-Haul truck. And he called me up and said, "Hey, Tom, do you know anybody that might need some masks?" I was like, "Yeah, like the whole state of Texas." So he was like, "Look, I've got this delivery coming up. I got a warehouse over in East Austin." And I was like, "Well, I'm not an expert in masks, but, let me come over and just look at these things." And on my drive over, I gave
I need
John
to do another
Henderson
trip,
a call.
so go. My dreams, bro.
Sorry, I don't know where that's coming from, but so John came over to the warehouse. I ended up taking, I believe, 8 boxes, sending some to Dallas, some to Houston. My son and I hopped in the car, drove to Houston, dropped some off because those were the hot spots. John actually had a plane fly down from somewhere in the Panhandle to pick up some masks, had several hospital administrators drive in from West Texas to pick up masks. And the LA Times ended up running a story about, masks from Mexico. I had suggested the title of Hecho in Mexico, but I guess the editors didn't go for it. But it got quite a bit of national attention, and I think for probably the next month, I got somewhere between 8 and 20 phone calls and emails a day from entities or groups who had family or friends in China that had this magical supply of PPE, and I'm sure everybody's read the story of all of the fraud and other things that have occurred there. But yeah, John and I kind of joked, because I had a lot of friends that read the story, clearly not closely, and said, "I cannot believe you drove into Mexico to get masks." I said, "Well, I drove to East Austin. It wasn't that far." It's a fun story to tell.
Great story. We appreciate the story. We have a group out here in West Texas who we call the 3D Printing Consortium, and it's a bunch of people who own 3D printers who were mobilized and printed face shields and all sorts of good stuff and saved the day. And we were happy to connect hospitals and people with those supplies. So, the thing about rural America and rural Texas in particular is we solve our problems as quickly and innovatively as we can. And the AHECs were instrumental in that.